in such way that they will cover entire gamut of conditions, right from the vascular access till the advanced IR. And without wasting much time, I will introduce. It's my honor to introduce our master for today's class, Dr. Gaurav Gangwani. He is a young, dynamic, inspirational interventional radiologist working at Bhakti Vedanta Hospital and Research Institute. He has completed his fellowship in IR from Gangaram Hospital, Delhi, and has over more than 10 publications to his credit. And he has delivered many lectures, presented papers, posters, and have been invited as a faculty at many national and international conferences. His main areas of interest are venous interventions, peripheral artery disease, stroke, and epidural interventions. And he will be speaking about the role of embolizing agents, right from basic blood clot to the advanced embolizing agents, and their mechanisms, and what are the tips and tricks for doing the procedures. Over to you, Dr. Gaurav.
Thank you for that introduction, sir. Without wasting anyone's time, I'll straight jump into the presentation. So I'll just share my screen. Yeah, I hope participants can view my screen and my PPT, and I am audible also.
Yes, yes.
Yeah. So I'm just starting in a second. Before that, I'll just apologize if there is any fluctuation because of storms and rains here. We are experiencing a lot of Wi-Fi fluctuation as well as mobile networks, but hope it pulls off well. So I'll just get my pointer and we'll start. Yeah. Thank you, everyone. So today's masterclass is on embolizing agents. And before I start the webinar or the lecture, I'll just say that there's no particular embolic agent of choice for a particular indication. This embolic agent of choice is so dynamic. It depends on so many factors. And every day we are learning that more and more different embolic agents can be used for different indications. So please know that as we speak, the data is changing daily, the experience is changing daily. So, but let us go through whatever knowledge we have till now, and let us see how we can improve. Also, a disclaimer: I am no expert or master at embolic agents. I don't think anyone can claim to be, but yes, at least whatever data I could research and with my personal experience of a few years, I'll be happy to share. No conflicts of interest, no financial disclosures, and not all images or graphics are my own, but yeah, 70 to 80% are. So when we talk about embolizing agents, there are various agents or groups that we can talk about. They start from temporary agents like gel foam and autologous blood clot, also being the cheapest ones. Of course, there's the standard thrombin for pseudoaneurysms, and then even people have gone to the extent of using sutures, cutting them and using them as embolic agents. So which is not a very bad idea. Sometimes in a resource limited settings, you have to do things like this, and they do work in good hands. Then, of course, we have many permanent and durable agents with starting with particulate agents or particle agents like PVA particles and embospheres. We have liquid embolics like onyx, quid, and fill for the neuroliquid embolics, as well as glue, which is more often than not used in the peripheral system. And of course, we also have the standard focal metallic occluders like the coils, fibered and non-fibered ones, as well as the Amplatzer vascular plugs, which are used more for focal and proximal occlusions. Of course, we'll see these things in detail. I'm just giving an overview before we start. And then there are some miscellaneous agents which I've grouped in the end, which are not very rampantly used. They have few selected indications for which they are used, and they are absolute alcohol, detachable balloons. Cetrol is used in occasional cases for embolization, the indications of which we'll see. And of course, we have this proprietary adhesive, which is nothing but glue, but yeah, with a special proprietary formula, which makes it a little viscous. So you can use it for varicose veins and truncal veins. So yeah. So before we jump on the utility of embolic agents for different indications, let us see the definition of embolization. It need not be a textbook definition. Let's just see what is embolization. So embolization is the deliberate occlusion of vessels. So if interventionist occludes vessels deliberately, then it is embolization. Whereas if it happens naturally by body clot, then it is thromboembolism. And of course, the purpose or the intent most of the times is a preventive or a therapeutic closure of that vessel. And mind you, I'm not talking here about blood vessels. It can be embolization of lymphatic vessels or sometimes even other tubular structures. We'll see few of the indications. And it is usually performed, but not limited to, most of the times preventing or occluding bleeding vessels, sometimes devitalizing a tumor as a curative or a palliative intent, sometimes even as a pre-operative ancillary measure so that the operation can go on smoothly with less blood loss and less requirement of a PCV transfusion. And many times to devitalize a normal organ or a enlarged pathological organ, but not malignant or mitotic etiology, so that we can achieve its shrinkage and relieve some of the pressure symptoms that it's causing because of its size. So let's jump on to just see a few indications where these are used, and then we'll go to each embolic agent. So as we saw, first it is used to prevent or arrest bleeding. It can be used for hemoptysis or hemoptymesis. Hemorrhoid embolization or even other GI bleed embolization is pretty common. Sometimes the only measure when endoscopy is not achievable or the bowel preparation is poor. Uh, we, of course, the standard aneurysm bleed and aneurysmal rupture leading to SAH and embolizations, or even the peripheral aneurysms, visceral trauma leading to kidney lacerations, renal or splenic or hepatic injuries need embolization, and of course, postpartum hemorrhage is something which needs embolization. It is still not met its need in the resource limited countries, but it is ramping up in a big way. The second is to devitalize a tumor as a pre-op indication, like a large vascular meningioma or a paraganglioma or a osseous metastasis from a hypervascular primary like an RCC. But then it can also be used as a standalone therapy in benign tumors like angiomyolipomas, for which it has really become one of the first disciplines or treatment measures of choice. Now, to coming to devitalization of normal structures or benign lesions, which are not necessarily mitotic or malignant, but yes, embolizing them causes shrinkage and relieves some of the effects from them. It's very commonly used for uterine fibroids, and the huge gap is still there because of awareness. But yes, uterine fibroid embolization is one of the standards of care and alternatives now. Prostate artery embolization is being used in a big way for BPH, and earlier it was thought it can be used for moderate sized prostates, but now we are realizing it can be used for giant prostates as well. Varicocele embolization is a very good alternative to microscopic ligature of the varicoceles or the pampiniform plexus, because you can see the variant anatomy and you can glue or embolize all of them, and that's why it's a very interesting alternative. Recently, after the work of Dr. Akuno and then following in the footsteps, American work, and of course, many of the Indian centers like Gujarat are doing it in a big way. MSK embolization techniques are coming up in a big way, and more embolization is being used for, of course, knee osteoarthritis as an alternative to knee transplant, but many other indications like plantar fasciitis, frozen shoulder, and inflammatory MSK conditions. Of course, it's now come in a big way. Many studies are coming in the form of thyroid artery embolization, where it's used for multinodular goiters, large thyroids, even those with retrosternal extension, as well as non-Graves hyperthyroidism. So these are various indications for it. So it's a huge emblem where we talk where embolic agents can be used, and that's why it is very important to know which indication requires or warrants which kind of embolic agent and subtle details of using each agent. I, of course, tend to group AVM in the end because it's a very different kind of ball game altogether. It's all about uh, different types of AVM ranging. You can use various classifications like Chodo, etc. But I follow the recent Yates classification where the type 1 AVM can be as simple as a simple arteriovenous fistula. You can have the type 2, which is usually a nidus and then the veins. You can have a type 3A, 3B, where the nidus is actually in the venous sacs, the wall of the venous sac, and therefore no matter how much you embolize the feeding arteries, until you embolize the venous sacs, it's going to recruit new and new feeders. And type 4, the most complex one, where the nidus or the nidal vessels as well as the normal capillaries are intermixed. So these are the most difficult ones, because if you embolize the normal capillaries, you are going to end up with non-viability of the end tissue, which you don't want, the normal tissue. So it's a very complex entity, and yes, it has its own measures and own principles for treatment. So as we go through the embolic agents on a case basis, we will go through them. So how do you choose a particular embolic agent? What are the factors on which you decide? Because whenever you have a case, there are so many options you have to choose from, and it is based on so many things. You have particles, you have liquid embolics, you have coils, you have amplats and plugs. and many of them are compatible with most of the microcatheters we use. So it's a tough question, and it's based on multiple factors like the vascular territory that has to be embolized, whether the parent vessel from which the bleeding source is arising, whether that can be sacrificed or whether that needs to be preserved, the level of occlusion desired, whether you need a proximal occlusion or you need a distal end organ occlusion of the capillary bed to achieve shrinkage, whether you need a permanent or a durable embolization or just a temporary embolization will do, like a pre-operative setting where you just need to embolize so that the surgeon can get a bloodless field. How good is the stability of your delivery catheter, whether you are selective or you are good amount of super selective, you have either reached the mouth of the bleeding point or even crossed it into the distal circulation so that you can have a good backdoor and front door occlusion. How is the profile of your delivery catheter that you're using for the embolization, depending on the vessel, of course. And one of the most important things which we usually neglect in the embolic agent choice is user experience. I can vouch for this. There are colleagues of mine through the Med Twitter platform where we have connected who use Onyx regularly as a balloon assisted ancillary technique to occlude intracranial aneurysms after putting the framing coil, and they are doing it in huge numbers without a complication. But someone who does not have that kind of experience, I would never recommend that kind of a technique, to use a liquid embolic in a brain aneurysm just with balloon occlusion, because there are a lot of challenges and issues that can arise with that. We of course regularly see cases by our colleague Dr. Ajit Yadav, who uses glue like coils and goes in pseudoaneurysms or even true aneurysms and embolizes it with a lot of control. But glue can be a very dangerous agent at the same time. So many of these agents are versatile, at the same time dangerous, but a user experience matters a lot. That's why not an agent, maybe a agent of choice for a particular person may not be the same for other, and it's always best to put safety first rather than efficacy first. No doubt we want efficacy because whatever we are doing, we want results in the end. But yes, nothing is over patient safety first. So if you're not confident, either change the embolic agent or get a proctor, get help, get guidance, get good and better in that in experience of using that agent, and only then switch to it. So without wasting any time, let's delve into a case-based scenario and let's see some cases and understand what would be the particular agent used in that scenario. Of course, had it been a longer session, we could have made it didactic. So I'll continue and we can take questions in the end. So let's start with temporary or non-durable options and let's see some cases and how we can use those options. So this was a case, Lirat's 5 lesion, classical cirrhotic patient with a hypervascular single solitary mass in the liver showing washout, a delayed pseudocapsule. So of course there was signs of portal hypertension like varices and ascites. And the medical oncologist calls me and says, hey, I need a biopsy for this lesion. I tell him, sir, it's Lirat's 5. Why do you want a biopsy at all? You can just go ahead with the treatment or refer it to us. We'll do a TACE, or depending on the size, a TACE plus a ablation. But he said, no, I want to include it in a recent clinical trial on immunotherapy, and the trial mandates, the trial sponsors mandates that they need a histopathological correlation. Well, whatever the need be, nobody's going to save you from a medical legal soup if you end up with bleeding because of the CLD, the dysfunctional platelets, deranged INR, hypervascular lesion, and ascites. So, but at the same time, you have to honor the request because sometimes it is important for that trial. So it's not a complete, you can't be very rigid and you have to biopsy it. So because of being an IR, you can of course always drain the ascites and then plan for a plugged biopsy, where after the biopsy, you can use the coaxial needle to plug the track. There are various agents you can use to plug the track so that it doesn't bleed, for prevention of bleeding, as we saw one of the indications. I always prefer the gel foam slurry, just for the basic fact that it is one of the cheapest agents and most effective. So if I get something which is completely effective and cheapest and easily available, why not? So this is how you prepare the slurry. You cut the gel foam into multiple linear strands, and then you may cut it horizontally to make pellets, square pellets out of it. This is the gel foam cover. Just for ease, we are collecting it on that. I'm sorry. Yeah. You can collect the pellets in a syringe, then take a second syringe with saline and just use a 3-way and the standard Tessari method to mix both the gel foam pledgets as well as the saline to make a slurry out of it. So let's just see the Tessari method being performed. Yeah. So this is just for a demo, but yeah, you can take sterile saline for the same. Yeah, so you connect the gel foam pledgets in one end, the saline in the other of the three-way. Yeah, and the slurry is made. So of course you can alter the saline according to your need of the consistency of the gel foam. Yeah. So this is how gel foam slurry is a very good embolic agent to prevent bleed after a hypervascular biopsy. This is a companion case. Again, a right paratracheal lymph node. The EBUS guided cytology did not give the desired result, and the sample said it was a reactive node. But the chest physician was pretty confident that there are tiny areas of necrosis and it is a pathological node. So we were called in for a biopsy. We were not scared of hemorrhage in this instance because you can go posterior and avoid all the SVC, the aorta and other vessels. Of course, the azygous tiny veins are there, but that's fine. But yes, you are scared of pneumothorax because you are actually puncturing two layers of pleura in this instance. And that is why, again, if you just plug the tract before coming out through the coaxial needle with gel foam slurry, it causes a good kind of tamponade, not only plugs the vessels, but also plugs the tiny bronchi that are there and reduces the chance of pneumothorax manyfold. We have been fortunate enough to do about 40 to 50 of these cases in the past 2 years, and I have not seen a single pneumothorax despite all these right paratracheal and subcarinal biopsies. And plug biopsy is definitely helping us, which is consistent with literature. It's not only my personal experience, but a lot of literature out there speaks about this technique where you can just plug the tract and you don't find pneumothorax as often. Of course, for the same plugging, you can also use gel foam torpedoes and just cut the same gel foam into rectangular pledgets and roll them up with your finger into tiny circular cylindrical torpedoes. You can fill those torpedoes in the coaxial needle, push them with the stillet, and just pull the outer needle back to the stillet so that the torpedo is deployed. This is a faster way of doing it. So places where you don't want to use a lot of slurry and you don't want it to go and enter into vessels or bronchi, this is an alternative. Most of the time works. I always prefer the slurry, of course. And like I said, it's all upon user experience and user comfort. So other way of using gel foam is, of course, scraping it and forming particles, either small ones or slightly larger ones. Of course, we do not have calibrated particles in India yet. Japan has a lot of calibrated particles where, like PVA, gel foam comes in different sizes, pre-calibrated and automated. And one of the reasons is they don't have PVA authorized yet by their medical system, and but they use gel foam beautifully like a permanent agent almost, and it works for most of them. So it can be used as the same indications for PVA, but yes, I will be not using them in places where the recurrence chances are high or the etiology is not correctable, like bronchial artery embolization, for instance, where I know that the fibrobronchiectasis is going to stay. So I'm not going to use gel foam because I know then the chances of recanalization would be a lot. So, but where can we use it? We can definitely use it for visceral bleeds. You can use it if you super selectively reach the hepatic arteries, the splenic arteries, or even the renal arteries where there are tiny lacerations or bleed, and you can definitely use it. Pelvic fractures, of course, you can use gel foam for bilateral internal iliac embolizations. And tumors, you can definitely embolize using gel foam, especially when you know that the surgery is going to take place within 24 to 48 hours of your embolization. So you don't really need a very durable embolization. And even if it recanalizes within 4 to 6 weeks, you know the tumor is already out. It's just for making the surgery bloodless and reducing the PCV need. So these are the various places where gel foam particles can be used, and very well used just as an alternative to PVA. But please understand that just because it is a temporary agent does not mean you can use it anywhere and everywhere. It has its own kind of consequences. 4 to 6 weeks of embolization followed by recanalization is not okay for any organ. Many organs will get devitalized and gangrenous by then. So this was a simple case of a post-abdominoperoneal resection of rectal CA, where a small infective collection developed posterior to the bladder and anterior to the sacrum. We my one of my colleagues tried inserting a pigtail, a Malacot catheter over a wire using the standard Seldinger technique, but while inserting one of the dilator just kinked the wire and tracked paravesicle, which caused, of course, we corrected it. He just pulled it back, got good stability of the wire and placed the Malacot. But that traction, that dilator and wire that went through across paravesical location that probably caused laceration of one of the collaterals. And that collateral we confirmed on the CT angio. So we knew it is a bleed from one of the iliac arteries, iliac branches, and angiogram immediately showed that it was one of the bleeds from the prostatic artery. So and the so we could navigate up to the vesicoprostatic trunk with the 2.4 French microcatheter that we had. We did not have a 1.9 French at that time on our shelf. So we embolized it using gel foam, understanding that okay, who cares this anyways. Cost was a big issue because this patient had come for a OPD or a daycare based biopsy worth 5 to 7,000 INR. And now we are talking about admitting him, PCV transfusion, and embolization. By this time, his HB was 4 because, as we saw in the CT, 5 minutes later, the kind of hematoma that developed, and he was already at a HB of 6.4 post surgery and post chemo radiation. So we embolized it, but like I said, gel foam, just because you're embolizing the vesicoprostatic trunk with gel foam doesn't mean a temporary agent. It caused heavy vesical necrosis because adjacent to the bladder, there was a lot of hematoma as well as infection. So that was also conduits. And because of that, he went on a lifelong Foley's because they did a bladder repair, but it became a small neo bladder, which never completely healed on the follow-up CT scans. Also, they had to reimplant the right ureter. They had to make a neo VUJ, which caused anastomotic stricture later on. And he also has a right hydronephrosis for which DJ was tried, but it kept recurring. So he's on a lifelong PCN. So just this simple embolization caused him to be a lifelong Foley's and a lifelong PCN. So that is the extent to which things can turn bad. So never ever think that if I am in a GI, similarly, if I am in a GI bleed case and I can't super selectively reach the bleeder, then if I use gel foam, I'll stop the bleeder also and won't cause gangrene. Gel foam can cause gangrene if it occludes, because even bowel cannot survive for 4 to 6 weeks without. So of course you may escape depending on the collateralization and a kind of bowel that you are embolizing. But you have to prime the relatives that for whatever reason I'm not able to reach the vasa recta or the superselective point, so I have to embolize proximally. I'm using a temporary agent with the hope that it may not cause a gangrene, but that is definitely a 50% chance that it would be there. And then you can proceed. Similarly, I have seen cases of bronchial and intercostal artery embolizations using people using gel foam for that for particular reasons, but then seeing spinal ischemia occurring out of it. So please do not do that. Understand that if even gel foam slurry enters the anterior spinal artery or artery of Edem-Keves, it is going to cause paraplegia. So be very cautious of it. So completing gel foam, now moving on to the next agents because we have to cover a lot. Uh, so now let's see a different agent, another temporary agent where its utility is, a few areas where it is still used. So this was a 24-year-old gentleman, got a pelvic trauma during skateboarding. 2 weeks later, came to the emergency room with priapism, non-painful though, non-painful priapism. Clinical diagnosis urologist said was non-ischemic priapism, and it was confirmed because when we aspirated blood from the corpora cavernosa, it was bright red, and analysis showed it to be arterial blood. Color Doppler showed that there is a cavernosal to sinusoid fistula because continuously in the corpora cavernosa there was turbulent arterial flow. And angiography was done that showed the right pudendal artery to have a large bleed. So we understood that it needs embolization right up to relieve the priapism. But he is 24-year-old, embolizing the pudendal artery, even a unilateral one with a permanent agent, may cause erectile dysfunction, which we don't want. So autologous blood clot was chosen as an agent. There is some literature which says that the efficacy of absorbable autologous blood clot is as good as a permanent agent, 74 versus 78%, whereas the chances of erectile dysfunction is very low, 5% versus 39% in permanent agents. Of course, with super selective nature of the procedure that we can do now, these numbers are going down even with permanent agents. But yes, this is a good option to be used in that instance. So super selective angio showed the pseudoaneurysm and the bleed and the extravasation that was going on, and that was well embolized and taken care of and relieved the patient. So all you need to do is aspirate 20 to 30 ml of the patient's blood, keep it in a petri dish for 4 to 5 minutes, allow it to coagulate, collect it in a syringe, and just inject it through the microcatheter. Usually 2 to 3 ml is more than enough. This is a very important second main indication of using autologous blood clot, so a companion case. This patient had constant orthostatic headache, not relieving with any kind of intervention. MRI showed excessive enhancement of the pachymeninges and the dura. So MRI was done, and finally suspicion of intracranial hypertension was there. So a CT myelography was performed, which showed that one of the osteophytes was causing a tear in the dura, and a delayed CT myelogram showed definitely showed leakage outside the dura. So we understood that it's a dural leakage. And for this, autologous blood clot was used again, mixed with contrast and just injected as a epidural blood patch, which is proposed to cause tamponade as well as raise the CSF pressure at that and cause spontaneous sealing of that leakage. And follow up, you don't see that kind of enhancement, even the patient's headache resolved. So epidural blood patch is, you can do it of course in the lumbar area generically, but if you know the site of leakage, you can go and do it there. You will require a very less amount of clot that, or autologous blood clot for the patch, and it would be more effective. So this is one more area where this can be used. uh, Coming to next, many times post cardiology punctures and post PTCAs, and of course sometimes post IR also. It's not that we are free of pseudoaneurysms. You see these kind of pseudoaneurysms on Doppler, and for them a very simple intervention is the thrombin injection. Just use the standard TESEL kit, combine the thrombin with the calcium chloride, and just take your 22 gauge needle under ultrasound guidance into the neck of the pseudoaneurysm. In this case, the center had anechoic patent flow, so they took it there because it was a matter of time before the periphery also lyses if you don't do anything. And then just inject the thrombin, wait for a few seconds, and you'll nicely see it completely occlude. Yeah, and the Doppler is nicely showing, that's just the artifact from the needle, and otherwise the Doppler is showing the occlusion of the pseudoaneurysm, which is persistent over time. So it's a simple embolic agent to use. Of course, there's many alternatives for femoral pseudoaneurysms. You have fibrin, collagen, which usually requires large sheets. Covered stents, not a good idea in the CFA. You don't want to jail the profunda. Angioseal, recently a colleague showed how to use angioseal to clog off these neck of the pseudoaneurysm with an excellent result, and I do agree it's a good novel alternative. You can, of course, some people have tried coiling at the neck or within the pseudoaneurysm, and that has worked to induce rapid thrombosis. And surgical repair, don't forget it. It's not that always you have to embolize or use an embolizing agent. You can always refer for surgical repair. So completing that, the temporary agents or the agents with a very few indications like thrombin, let's now jump on to the permanent agents, embolic agents, and let's see their utility. So whenever you want to occlude a giant vessel, you can't do that with particles or smaller embolic agents. You would require a focal large embolic agent that can occlude the vessel completely. So if you want to occlude the Swiss canal, only a large cruiser ship can do that, and tiny boats won't do anything to it. So what are these proximal embolic agents? They are coils, both fibered as well as non-fibered, which can be very well used. They are Amplatzer vascular plugs. And of course, now newer and newer devices like plugs are coming into the cranial circulation, like the web device, the contour device, which have different properties ranging from occlusion of the aneurysm or the vessel to causing some differential flow diversion. So coils or plugs, these kind of proximal focal embolic agents are being used for true aneurysms, pseudoaneurysms. The principles vary, which we will see. For type 1 AVMs, which are actually AV fistula. So even if you just coil the arterial inflow, you are done away with the fistula, and you don't really need to do something extra for that. For visceral embolization, where you require a proximal embolization to reduce the pressure head, like for portal hypertension, especially when indications like hepatic NCAF are there. You may do a splenic artery embolization with a proximal occlusion alone without using any distal embolization in trauma, where reduction of the pressure head reduces bleed in most of the cases. Many articles are showing that result in hypersplenism and portal hypertension. So it's working wonders. You can also use focal occlusive agents in portal venous hypertension interventions, especially in cases like hepatic encephalopathy in CARTO. Of course, in CARTO, you combine it to reduce the varices with other agents. But yes, it's a very good tool. You can use these agents for parent artery occlusion. And finally, sometimes, like suppose you're doing a tear and you want to occlude the non-target collaterals, or you're doing a prostatic artery embolization and you want to occlude one of the collaterals going to the corpora cavernosa, you can use these focal agents, and they are very good agents of choice. They will occlude the artery focally. They will not cause necrosis of the end organ, but yes, they will definitely reduce the pressure head. So let's jump in and see a few cases where coils can help. This is a 63-year-old female with grade 2 SAH, a simple narrow-necked aneurysm arising from posterior wall of the supraclavicular ICA. And in this case, you can simply use a coil to completely occlude it. And it's a very standard way and nothing new to it. Just put a framing coil and then some packing coils and pack the aneurysm completely. So there are various ways you can do that. So, and then if you just pack the coil and pack the aneurysm completely, in this case, well performed with occlusion of the neck also, then the aneurysm is taken care of, occluded, and the parent vessel is still preserved. So usually you would do this with detachable coils because you can't use pushable coils because they may deploy early into the vessel and cause a parent vessel occlusion or thrombosis. Even eccentric thrombosis would be deadly. So these are good coils where you can completely deploy the coil and detach it only once you're confident that it is completely into the aneurysm sac and the parent vessel is free of it. So, and of course, whenever needed, you can always use assistance techniques. For example, this case, you can see that the coil is entering again and again the parent vessel because it's a huge neck. So there's no way you can pack it well. This is, of course, one of the Mentis simulators. So there's no way you can pack it well without assistance. That is why you use a balloon assistance. And this time after balloon assistance, if you push the coil, because the balloon is there across the neck, the coil will get a good frame within the aneurysm, the first coil, and then you can subsequently coil it. Whenever required, you can use the assistance again. This is a simple stent assistant coiling. There would be cases where even a balloon may cause a good framing, but as soon as you deflate the balloon, the entire coil mass can prolapse into the parent vessel. In these cases, you cannot just use a balloon assistant. You will have to use a stent assistance, and this is a good option in such kind of cases. For example, this is a wide neck aneurysm non-dependent. Even if you would use a balloon and push the coil mass, it may prolapse back. And let's see a good example to show same. And this is a good aneurysm where a stent assisted coiling would be needed. So see how stent assistant, you can go through the struts of the stent because they have enough space for allowing a microcatheter and a wire to go through, and then you can coil it pretty simply. Again, a framing coil and the packing coils, and you're done. The stent would hold it in place. Of course, one catch of this is you'll have to use antiplatelets because you're putting a stent, but that's fine in most cases. So sorry. Yeah, so we can see this aneurysm, how it is a very wide necked aneurysm, very lobulated irregular aneurysm, and no way, even if a balloon is able to push the coil mass into the aneurysm, as soon as you deflate the balloon, the entire coil mass is going to fall back. So you can use one or as many as two stents like this case, give ample support, and then nicely coil the aneurysm without much worry. So this is how you can use ancillary techniques. And now for wide neck aneurysms, more and more alternative options are coming up. Like you have the web device, and you also have the contour device from a Candice and the web device from Microvention, and you can use them. This is a case where a contour device was used and well placed, and it caused near complete stasis almost instantly. And this is a basilar top aneurysm where a web device is being placed. So the micro wire is getting anchored into one of the superior cerebellar arteries, and with support, once the microcatheter is well, it's navigated into the true aneurysm at the basilar top. Yeah, here's the web device being introduced once deployed and opened up. Yeah, nicely deployed and pushed. Yeah, and even at this point, it's not deployed yet, it's not detached. You can take a run, and then once you're confident that none of the vessels are getting affected and the aneurysm is nicely occluded with a good contact with the wall, there's no need for any alternation. You can then detach the device and continue with the further run. So good. Yeah, now the device is detached and the microcatheter can be withdrawn. So let's see a different case now. So all this was for intracranial cases, most of these where you need to just occlude the aneurysm and preserve the parent artery. But then there are always going to be cases like peripheral cases, especially where that much of precision is not required. You can actually occlude the parent artery either superselectively or sometimes even large arteries without much need for preserving them. So this is a case of multiple splenic pseudoaneurysms due to trauma, and you just super selectively catheterize that segment and occlude it completely with a coil. Being an end artery, even a proximal coiling is enough. You don't need to really go somewhere distal and do something, because there's splenic arteries being terminal end arteries, you won't get collateral flow recanalizing these again. So a simple proximal front door coiling is enough, and then the pseudoaneurysms disappear. And of course, you can use pushable coils in these cases, because you don't have to be that precise to use detachable coils. If you have that kind of finances, there's no harm in using a detachable coils. It would be more precise. Another simple post PCNL pseudoaneurysm case where a simple coil can go and do the job. You can just anchor it into the supraselective vessel. Even if it extends and causes occlusion of this whole branch, doesn't matter. Anyways, it's non-viable kidney there. So you just clog the aneurysm again, renal artery and end artery. There's no way that just because you're occluding the front door doesn't mean that the aneurysm will get refilled from the back door, because it's an end artery. So even a front door occlusion is enough. And again, pushable coil is enough. You don't need to spend anything extra here. It's a very simple procedure. A companion case, a pulmonary AVM case, as we discussed, pulmonary AVMs most of the times, if not, are type 1 AVMs or simple AV fistulas. Even if you occlude the inflow artery, that is more of the times than not enough, and you do not need to do anything special like backdoor occlusion or nidal cannulation or any such thing. Just a simple complete occlusion of the front door suffices. Just a companion case to show that this is not, of course, not from India, that a simple microvascular plug can also do the, or a major large plug in such a vessel can, or single plug can replace all these set of coils and can also do the same function that a coil can do. So even a plug will cause proximal occlusion. So how, when you coil, how do you do coils in pushable coils? How do you, there are two techniques by which you can use. The first technique is the standard scaffold technique, where you use a coil with a high radial force and start deploying it, so that because of the radial force, it starts getting opposed at the vessel and does not really fly. Try to deploy the whole thing by weaving, that is pushing and pulling the microcatheter forward and backward. And once completely that's deployed and there's a good amount of radial force and the coil is held in place, then you can use softer, smaller coils or longer coils, and then achieve a good packing density throughout the coil mass, so that you achieve a very good occlusion and there's no risk of the coil migrating. But then there's an alternative to it, the anchor technique, where you can go super selectively into a vessel, anchor the coil into that branch vessel, and then start deploying the rest of the coils with the standard weaving technique again. And that's enough. Like this case, we can see how the coil has been anchored into the vessel, and through after the anchor, the deployment is pretty simple for this AV fistula or type 1 AVM. So we saw the difference for an intracranial case, how you have to go and coil and the packing density of the coil has to be achieved within the true aneurysm while preserving the parent vessel. But for a, and then there are cases we saw where you can just block the inflow, and that's enough because they are end arteries. You don't expect any backdoor recanalization like the splenic, the renal artery pseudoaneurysms, as well as the pulmonary AVMs or type 1 fistulas. But then there would be cases of peripheral system or even neurosystem where proximal coiling won't be enough. And in these cases, if you know they are not end arteries, if you just proximal coil, there would be backflow from the distal circulation and will go and fill the aneurysm completely. Like suppose there is, it's not an end artery and you occlude the inflow, from the other end, collaterals will refill the aneurysm, and this time it would be very difficult to reach the aneurysm because you have already occluded the inflow. So never do this mistake. You will have to occlude both the outflow and the inflow, known as the front door, back door coiling or occlusion, and only then you will be able to achieve complete occlusion of that vessel. So this is a CCF case, balloon occlusion, and it was planned for parent vessel occlusion, as balloon occlusion test showed that there was a very good ACOM and good cross circulation. In this case, if you just do a proximal coiling, the ACOM circulation will fill the opposite system and go down and fill the CCF again, and that would be a disaster. Because after that, if you want to occlude it, you will have to go all the way through the left ICA into the ACOM and down and then embolize. So that is why you start right from the distal end and coil all across the neck right up to the front door, the proximal end, and only then you will achieve a good occlusion and prevent any recurrence from the distal circulation. Another similar case showing a proximal true aneurysm from the mid-splenic artery. In this case also, if you just occlude the proximal system, you will get these gastric and pancreatic collaterals refilling the distal end and maybe refilling the aneurysm. The pressure head would definitely reduce, but then that's not guarantee that the aneurysm may not grow or rupture. And then imagine trying to take a microcatheter across these tiny frail arteries and going back and trying to embolize this, it would be a nightmare. That is why if you have to coil this case, it has to be a complete distal to proximal occlusion. Of course, you can also put some of the coils within the aneurysm sac. That is not a problem. That is optional. But yes, you have to occlude it completely distal to proximal. It has to be a front door, back door closure for any peripheral aneurysm, which is not a end artery. And plugs are plugs. There are various kind of plugs available, various types, the type 1, 2, 3, 4, and then there are various profiles, lengths and diameters available for it. So and you should know what kind of guide catheters they go through. So if you have a type 4 plug, it's a good one because it will go through a simple 5 French diagnostic catheter. There is no need to take a guide, but it is only available in a few diameters. Above 6 to 8 mm it's not available. So you then right up to 22 you have to take a type 2 plug, which is most versatile and commonly used amongst all plugs. And then each plug has its own property, and of course we can't go into those details in this lecture, but yes, you should know this. You can take a screenshot, study on your own in detail. Medtronic has also launched microvascular plugs which can go through microcatheters, and even O21 and O17 microcatheters can help deploy these, O21 and O27. So these are also good in certain kind of vessels, especially if they are smaller vessels like the type 1 AVM case we saw. Uh, a coil is just you can use at locations where you want to do away with a single plug instead of multiple coils. So a plug is just an alternative to coil. Like we saw non-target embolization, you want to do a tear, so you occlude the GDA with a plug. And of course, if it doesn't completely occlude, you can always use an ancillary coil and help it out. This was a case again of a patent splenic artery in a patient of hypersplenism. Again, a single plug did the job and occluded the entire splenic artery, and that reduced the hypersplenism and corrected the pancytopenia. A parto being done with a plug and a second catheter being used to inject gel foam so that the varices get treated. Similar companion case being done for the same. And so a parto is a good alternative to BRTO like a carto. So instead of a balloon, you can always use a coil mask doing a carto or a plug doing a parto. So these are proximal occluders as we spoke, and they work well. So after finishing the metallic focal proximal occluders, now let's see the particulate occluding agents, which can actually go and clog a vessel completely, especially the distant circulation when a good shrinkage is desired and a capillary bed circulation occlusion is desired. For this, we have the PVA particles as well as the embospheres. The only difference is that embospheres are more uniform and tend to aggregate less, but practically, when studied, it has been found that only the smaller embospheres do not cause much inflammation, unlike their PVA counterparts. Otherwise, there's not much difference, but the cost is nearly double. So you can be wary if you really want to use embospheres. Otherwise, PVA are good enough for most of the indications. So this is our case, which came to us, a young 32-year lady who, of course, did not have started the family, but had large fibroids and multiple complaints. One of the fibroids was degenerated, and the patient was given the option of hysterectomy or even if myomectomy. The patient was warned that the scars would be so large that she would have difficulty in conceiving later a normal delivery or even a cesarean one. So the patient asked us for uterine artery embolization. Usually you tend to use PVA particles for these because you want end organ ischemia, you want capillary bed necrosis so that all this vital tissue dies. And we did the same. We used particle agents or PVA particles. We took our microcatheter deep, and whenever we could cannulate right the fibroid feeder, we used even smaller particles like 100 to 300, because the tinier the particles the better. It will cause complete necrosis. But if you are in a proximal location, I would not suggest to do that, because they can also then cause occlusion of the spiral arteries or the endometrial arteries and cause endometrial necrosis. So the more proximal you are, the larger particles you used. If there is shunting, you tend to use larger particles because you don't want the particles to go into shunts or non-target collaterals. But if you are distal, there is no shunting or collateralization, then of course you can use smaller particles. And this is the basis of the perfected technique which is being followed now, where proximally you use larger particles, and then once you come distal, you can use smaller particles. Similarly, right uterine artery was embolized, not much fibroid flow through that, but still it was embolized. And in the end, we achieved a good stasis, and finally on the follow-up MRI a month later, we could see complete necrosis of both the fibroids and a very good result. Similar companion case, this was one of the prostatic artery embolizations which we have performed. A BPH case, giant prostate, 175 grams. and the patient had complete urinary retention and was Foley's dependent since the past 6 weeks. They tried 3 attempts at removing the Foley's on medication, couldn't. Placed him for a HOLEP, holmium laser enucleation, but the patient did not want a surgery no matter what. So we did a CT angio because patient was referred to us for PAE. CT showed the prostatic artery. That same was mapped on the DSA, and finally under roadmap guidance, we could navigate a microcatheter across. This is the left prostatic angiogram showing the hemiprostatic blush. Again, a deeper navigation showing the hemiprostatic blush very well, and we knew that there are not much collaterals through it, but we always like to go right at the face of the prostatic arteries as distal as possible to avoid any inferior vesicle or a corporal collateral, and then embolize. Post embolization, we could see much good stasis in the proximal segments of the arteries with no parenchymal blush, and we were very happy. But when we took the right internal iliac anterior division angiogram to find the right prostatic artery, we found that it was an empty pelvis and we did not see any major prostatic artery going towards the bladder. So we suspected, we had the CT angio and we knew that this case has a variant. So we went in the external iliac artery and we could find the prostatic artery from there, navigated into that, and finally saw the prostatic artery from the right external iliac artery known as the corona mortis variant. And of course, we embolized that too. And post embolization, hemiprostatic blush disappeared with only stasis in the proximal arteries and a good angiogram showing external iliac angiogram showing that the prostate is completely embolized. And this patient went Foley's free after 2 weeks when we gave the first trial, and his prostate on USG showed that it was only a mere 90 grams now residual after just 2 weeks. And the patient said that he can again pass stream like a teenager again. So uh, sometimes this ischemia, especially if for this case we used particles as small as 150 to 250 microns, because both sides we could reach a very distal extent, and we knew that there are no collaterals or non-target areas which we want to avoid. Another companion case where PVA is one of the traditional agents of choice, hemoptysis patient with a very hypertrophied bronchial artery with lot of blush. And again, you can use standard particles. Standard size is 300 to 500 because you want to occlude them but avoid um, structures like artery of Adam Kivis or shunts. But yes, if you do see frank bronchopulmonary shunting or shunting to any other vessel, then you can even go for larger particles. Like we said, safety is first. Efficacy is of course important, but yes, you won't ever compromise safety. So usually 300 to 500 micron particles suffice. Of course, being permanent agents, still we do see, this is one place where we do see recanalization of the same arteries that are embolized because of the nature of the fibrobronchiectasis that is there. Now, like we discussed with the studies of Dr. Okuno and many other counterparts now, Dr. Bagla and Dr. Isaacson in US, many of these MSK conditions like knee osteoarthritis are being treated with embolization. So genicular artery embolization is almost a standard thing now, and very soon with further trials coming in, we should have FDA approval. Many of our Indian colleagues are doing it with excellent results in pain, even avoiding transplants, but even in post-transplant patients where pain persists, it's a good agent. Bariatric artery, and again, PVA is one of the agents of choice, PVA or embospheres. Small embospheres especially are being propagated for this. Morbid obesity, bariatric artery embolization is being propagated and nicely followed for these patients, and it is showing promising results. Of course, a few centers are doing it. It is not the standard of care yet, but very soon it might be. Again, PVA is also a standard agent which can be used for myriad of head and neck tumors like meningiomas, juvenile nasopharyngeal fibromas, and many other such things. So definitely remember that a good go-to agent for these is PVA. If there is no shunting, you can definitely use PVA particles. If you have a good distal reach, then you can even use very tiny particles like 55 to 150 microns even. But be careful of shunts like ECA to ICA shunts, which you may not see. So always be careful of them. Thyroid, for multinodular goiters and even Graves hyperthyroidism or non-Graves hyperthyroidism, now PVA particulate embolization is being tried, and that is achieving good necrosis and shrinkage of the glands, a very good efficacy. So definitely this has to be on the lookout. And out of the 146 arteries embolized amongst 51 patients, almost 50 patients say that 98% that they would definitely recommend this to others, because this avoids a huge lot of surgery and lot of potential complications which are especially occurring in such large thyroid. So please understand that the role is only increasing more and more with prostate, uterine fibroids, thyroid, bariatric, MSK, and so on. So particles are definitely going in a big way and pretty standard. Just be careful of the sizing. Very distal, no shunts, no collaterals. Go for the smaller sizes, better end arterial necrosis, but more post-embolization syndrome, of course. But if you're proximal and you are not sure about the shunting or collaterals, try to use larger sizes to avoid any non-target complications. Now coming on to the liquid embolics, which is probably the last section of our talk, and of course some miscellaneous embolic agents, and these are one of the most versatile but one of the most risky, especially if user experience is less. So of course AVM is a very standard indication where these are used. Type 1 you can use coils or plugs, no need for a liquid embolic in these. In fact, they are fistulas, liquid embolics may fly if not taken in the proper concentration. Type 2 and type 3 are definitely areas where liquid embolics can be used. Glue, I would say, is the agent of choice in all of these. Or if it's a cranial aneurysm, cranial AVM, then even these cranial counterparts, onyx and squid and fill can be used. So this is a case with young man with seizures, a large AVM. Onyx was used and nicely it could get occluded. So what do you do with these kind of agents? You just take a microcatheter if you're going through the arterial route in the distal feeding artery, as distal as possible, avoiding the proximal arteries or the lenticular striate arteries to avoid any stroke. Then you start injecting the agent to completely occlude the nidus as well as a part of the draining vein. Of course, taking care that the liquid embolic should not reach the outflow vein so that they do not cause venous strokes or venous hemorrhagic issues. So, but the nidus has to be covered. If you are just occluding the feeder, it's of no use. The nidus will have other feeding arteries or will recruit new feeding arteries. So you have to occlude the nidus, especially if the AVM is type 2A or 2B, where there is a lot of nidus involved. There is a variation of type 3A, 3B, where the nidus is actually the wall of the venous sac. And in these cases, venous approach is the best, but irrespective of the approach or access you take, you have to completely occlude the venous sac. If you don't, it will recruit newer and newer arteries because you have not included the nidus, which is there in the venous wall actually. So what is the difference between these neuro agents, onyx, squid, and fill versus glue? Glue polymerizes and forms a dense cast, whereas onyx or squid or fill precipitates and do not form a adhesive or a dense cast. It rather forms a lava or a spongy cast, lava-like cast, not a very hard glue-like cast. And of course, both are compatible. But second, of course, glue you can change according to the dilution, whereas onyx, there are few defined concentrations available, but with options of squid and fill, there are more and more options coming up. So basically the advantages of onyx or squid or fill is that you have more controlled embolization, longer injection times, of course, because it takes a lot of time for peripheral casting, and then you can still keep injecting for it to penetrate further. But yes, better forward penetration and definitely better filling of the target malformation. So for neuro cases, definitely would prefer onyx, squid, or fill. But for peripheral cases, of course, glue, because of the cost as well as because of the versatility by which you can form the dilutions right from 10% to 90%. So I'll just show a few peripheral cases also. This was a proposed uterine AVM, but actually this was a enhanced myometrial vascularity. There was no early venous outflow. HB was 4 because of bleeding. This is the left uterine angiogram showing, of course, this was showing some early venous filling, but yes, when we went with a microcatheter, we did not see early venous filling. It was only extravasation. So this was an enhanced myometrial vascularity, mimicking a type 3 AVM. So we went in deep. In this case, left side, we embolized it with PVA particles because they, like we said, there was no venous outflow. So it was safe doing that. But when we went on the right side, we found that there was some venous outflow and then there was some pseudo AVM forming, and we can't just inject particles. So we again went in my super selectively and injected glue this time. After the first feeder embolization using glue, we caused a stenosis and an injury to the vessel. And that is why we couldn't navigate the microcatheter again through that injury, which was having extravasation and spasm and a lot of issues. So that's why from that point on, we injected glue. And look at the beauty of the versatile agent. Even though there was a stenosis and an injury, there still glue traveled nicely all across, caused occlusion of the distal circulation as well as the feeder artery, and caused a nice occlusion. And then there was no more the residual blood seen. Still, we could see some venous sac or some extravasation in the vagina, and we just entered transvaginally into those sacs and we injected glue. So, one of the beauty of the visceral or the peripheral system, unlike neuro, is that you can take a percutaneous or a transvisceral punctures and you can again use these agents. This is a companion case to show the use of liquid embolics. This was a lymphangiography showing a leak and some variant anatomy in the form of two channels going across the thoracic duct. So first a microcatheter was passed and coils were used to occlude one of these channels, and finally glue was, so yeah, coils was used for to occlude these competing second channel, and then after the coils nicely glue was used to occlude and form a big cast across the thoracic duct, and post that we achieved a good complete cessation of the chylus leak that was occurring. Uh, yeah, this was an interesting article I came across by a Ames team, and this was very interesting of how glue can also be used with modified techniques in pseudoaneurysms. So they had proposed that there are many practical instances where the techniques that we talk about are not possible. For example, suppose you want to save the main artery, so you can't do a front door or a back door coiling in these instances. Or you take the microcatheter, but due to tortuosity or stenosis or issues, you are not able to go distal to the aneurysm to cause a backdoor coiling. Then what do you do? Third case, you have coiled back door to front door, but the aneurysm has picked up new collaterals through his fundus or through alternate collaterals, and that's why the aneurysm is still growing and picking up flow. And finally, the landing zone is so short that you cannot deploy a coil there. So these are practical issues, and they navigated all of these issues and troubleshooted with glue. So this was a case where they wanted to preserve the parent artery because otherwise the hepatic right lobe would not get its hepatic supply and you have a risk of biliary ischemia. So they entered with a microcatheter into the neck of the pseudoaneurysm and finally the pseudoaneurysm and just injected glue and occluded it, completely preserving the parent artery. Second case which they showed, they navigated all across right up till here, but they couldn't go into the distal circulation. So from that point, they injected dense glue, which made it into the distal circulation, back door closed, aneurysm closed, front door closed, and excellent occlusion. Third case, they coiled the pseudoaneurysm, but they could see some flow by Doppler, and then finally they went through transcollateral to the microcatheter till whatever point they could reach. And finally, from there, they injected glue and completely embolized the pseudoaneurysm. And fourth case, where the left gastric artery had a very short stump, and definitely they couldn't put a coil here because there was still residual filling of the pseudoaneurysm of the aneurysm, and so they injected glue from that point and again complete occlusion achieved. So this was how beautiful in the good hands, in experienced hands with you can troubleshoot these indications and even use glue in pseudoaneurysms. But again, be very careful. Like I said, this can be disastrous in the wrong hands, and don't just say, just seeing this paper, don't think that pseudoaneurysms can glue becomes the standard of care. These were very valid indications where there was no other choice, and with good expertise these were carried out. This was our companion case. Erectile dysfunction came to us. Ultrasound was suggestive of veno-occlusive disease and venous leaks. It was confirmed with pharmacocavernosometry cavernosography. We took a deep dorsal vein puncture after confirming an internal pudendal leakage, and we embolized it with glue. So this is all glue cast, and further we could see still some leakage persisting, and we again embolized it with glue further. Still some leakage. So finally, before coming out, we embolized it with, yeah. So these are all glue cast now, not much leakage. Still, to cause a deep dorsal vein occlusion like the urologists do ligature, we just filled it with glue cast and came out before removing our micropuncture sheet. And this is how completely the internal leakage was filled out. The patient had a very good result. The erectile dysfunction resolved and the IEF score improved significantly. This is the last drop of glucose, and we came out causing complete occlusion of the deep dorsal vein like a ligature. So glue is a very versatile agent, and soon more and more papers are coming where they are talking about glue replacing all of the standard particle agents. So bronchial artery embolization, we'll all know that PVA has been the agent of choice for decades, but there are papers which shows that if you use glue, Korean experience, then the chance of same vessel recanalizing is very low as 1.8% versus 21%, where out of 270, 58 cases recanalized if you use PVA, in the best of hands, of course. So that's why, although new collateral circulation can occur in either case, but same vessel will never get recanalized if you use glue, because it is a costs a very hard cast, unlike PVA where fibrobronchiectasis can cause recanalization. We have just started mastering prostate artery embolization, and now already there are papers which say that glue can replace PVA, reduces radiation dose, reduces fluoroscopy time, and it's a very fast acting agent. Portal vein embolization glue has completely replaced PVA plugs. In fact, studies are saying that it causes more organic shrinkage of the liver to cause compensatory hypertrophy of the opposite lobe. And varicocele embolization also, STS plus coils has become very comfortable agent by many. But now studies are showing that glue is having lesser recurrence because you can nicely penetrate it across all the variants. So of course, I'm not saying that glue has already replaced this. It will still take time for it to be uniformly replacing these, but it's a very big food for thought how, and if you start getting trained with this versatile agent, it will be very good, and it may slowly become the standard of care. But again, be wary of the dangers. If embolized, it can lead to disastrous consequences. Just a short note on miscellaneous agents, because we'll be completing in the next 2 minutes. Uh, we can Cetrol can be used in the standard traditional BRTO technique. It does not always have to be a CARTO or a PARTO. Saves on the cost of the coils or the plug. Simple balloon, and you can inject Cetrol, keep it for 4 hours, and then deflate the balloon, and it works very well for them. It can also be used, as we know, for varicose perforators as well as superficial collaterals, and for varicoceles along with the coils. It has been a very good agent and used since decades, and it's worked well. Of course, there are recanalization chances, but it works well. Absolute alcohol has been used for AML embolizations, now becoming the standard of care in few of the countries. Also, type 4 AVM, especially occurring in the pinna, where the capillaries are almost interspersed with the uh, AVM nidus. There, absolute alcohol works well, because any other agent you use, even glue, it will actually cause capillary occlusion and cause necrosis of the pinna skin. But absolute alcohol, if used, it enters the least resistant pathways first, because the of course the direct arterial to venous fistulas are the least resistant, so avoids the capillaries and the resistance bed, and avoids skin necrosis while reducing the AVM. So it's a good agent for type 4 AVMs. People have even used it for type 2 and type 3 AVMs with a tremendous result. But again, like glue, it is a dangerous agent, because you have to be very wary of the pulmonary pressures, because you can't, like glue, it is not forming a cast, it is actually going into the pulmonary circulation. Detachable balloons, not many indications today, probably used only for parent vessel occlusion and CCFs. Not many people use it. I have occasionally seen cases coming from the Coimbatore group, but I think getting more and more obsolete. But yes, CCF is one place where it probably can work well. So just ending with this, if we have time, we can take a few questions, and I would definitely thank the authorities, Dr. Chandrasekhar and the entire ISVR team. I know that I'm not the best at embolization. I can't claim to be that, and there could have been so many people who could have taken this, but thank you for giving me this opportunity to help my junior colleagues in whatever way I could.
Thank you, Dr. Gaurav, for this wonderful lecture. You have covered most of the points, and all the points highlighted by your lecture was very apt and very practical. Let's look at some of the questions. Iliac hemangioma agent of choice. Your take on glue. Ashish Sharma, Dr. Ashish Sharma has asked.
Sorry, which hemangioma they are asking?
Iliac hemangioma.
Iliac hemangioma.
Sorry, ileal hemangioma. Sorry, ileal hemangioma.
Oh, so they are talking about a small bowel hemangioma.
Yes.
Okay. So I would like to clear that whenever we talk about hemangioma with the newer ISSVA classification, we are meaning to say a vascular tumor and not any mimic like a slow flow vascular malformation, which was earlier coined as a hemangioma. So of course, I don't have any generic answer for that. It would depend on so many things, including the kind of supply that it has, and the whether the bowel supply is intermixed with it. But I would say standardly now, more and more, for example, the hepatic hemangiomas, where we traditionally do a lot of arterial embolizations, we are realizing that these are slow flow venous malformations, again mislabeled, and we use bleomycin for them. Even for giant hemangiomas, we have seen excellent results. Personally, I don't have any experience of treating a ileal hemangioma. So if someone else can answer that better, it's good. But I would say it would be a case-to-case basis. I can't say there's a generic answer to it of embolizing an ileal hemangioma.
And one more, Dr. Neelu Doot has asked you any tips to avoid glue-related complications.
Oh, yes. So glue-related complication, the main tip I'll say is whenever you inject glue, either use a blank roadmap like you do in the neuro system, where you're very careful of how the embolic agent is penetrating. Be very patient. So many times we see onyx injections lasting for 62 minutes, 162 minutes, and people are very patiently continuing without causing reflux. So be very patient. use a blank roadmap. If you are using in the periphery and you have an option, you can even use a cine mode. It would be a lot of radiation, but you will very clearly see the glue penetrance and the reflux. Any reflux, any issue where you're seeing a more reflux rather than forward penetration, or any excessive distal embolization, just stop there without causing further damage, without trying to be over aggressive. Remove your microcatheter, regroup, rethink, and then see if you can use any alternate agent. Just don't be hasty to complete the efficacy procedure when you're seeing things going wrong. And of course, take help. There are many experienced users of glue. Take their guidance, call them for cases initially, and then slowly, with using more and more, the more you use at different dilutions, the more you'll get better at it.
Okay, now no more questions. Just I will ask few questions from my side.
Sure, sir.
In case of trauma, the vessel will be in the spasm. How do you select the coil size?
Yes, sir. So, very interesting question, sir. To be honest, uh, it is more of intuition for me, because, like you said, definitely we have also experienced this. Sometimes the HBs for the patient is actively bleeding, the vessel is super spastic. So it's more of intuition. I would just oversize by more than what I would usually do. And again, even if I miss it by something, let's say I undersize and I make a mistake in calculation, to be honest, I'm not much concerned. It's fine as far as I am stopping the embolization temporarily. Because once the fibered coil makes a cast and causes thrombosis, it's very uncommon that once the patient recovers hemodynamically, the vessel will actually dilate and the coil will fly off. It most of the times will form a cast, form a thrombus, and get embedded there. So it's just intuition. I don't have a practical answer for that.
Okay, fine. And one more thing, in case of vasospasm, if you want to inject the PO particles, if it opens following the embolization, and is there any role of NTG before injecting, so that you can have a vessel size estimated, so that you can appropriately select the PO particles?
Yes, sir. Yes, sir, definitely. In fact, for many techniques now, like prosthetic artery embolizations, all the users regularly use NTG first. It achieves two things. One, as you said, it relieves the vasospasm, so definitely works for that, and you get to know the kind of arterial supply you are dealing with. But more than that, it also causes redistribution of blood flow. What we have seen is many times there are non-target collaterals to the corpora cavernosa of the rectal arteries, and as soon as you give calcium channel blockers or antispasmodic agents, these collaterals disappear because there's redistribution of blood flow to the parent bed, to the main target organ, and you don't need to then do non-target embolization. You can directly inject PVA. So definitely NTG works. We have tried replicating it to other areas like uterine or others, and we have seen it work. So definitely NTG has a role. Pre-embolization, you can inject NTG and then decide on your PVA agents.
Okay. And do you have any experience in mixing the different embolytic like PVA, alcohol, or you can sprinkle the alcohol over the gel foams and you can, I mean, these are, I mean, just a practical.
Yes. Sir, I had come across very interesting literature where people have mixed glue, lipidol, and cetrol, and they have formed a toothpaste-like material, a toothpaste-like embolic agent, and they have used it in pig models in brain aneurysms, and they have seen that you can actually deploy it like a pushable coil and or a detachable coil, and very nicely like a toothpaste, it comes out and doesn't embolize. So it is a very huge unexplored sector. I have not done it much with PV and alcohol, but have tried it with others and has worked well. There is a colleague, like I said, who puts a framing coil in the brain aneurysms, inflates a balloon assistance, and then injects onyx throughout. We recently saw Rene Chapeau showing cases of flow diverters and then covering the aneurysm with a cast of onyx. So people have been combining these different techniques and works well. I haven't mixed PVA with alcohol, but I definitely think it can be done.
Even you can sprinkle the absolute alcohol over the gel foam particles or slurry, it can have an enhancement in the this one.
Okay.
Okay, one more thing, if microcatheter is stuck in the glue cast, what do you do?
Sorry, sir, can you please?
Microcatheter is stuck in the glue cast.
Right.
What do you do?
Okay, sir, if I'm whether, especially to start with, I would say prevention is a better option than actually dealing with it later. So if you're doing a brain case where you know the penetration time will be more, always use a detachable microcatheter, either the standard Sonic from Balt or the Apollo from Medtronic. But in case, let's say you're not prepared for that, and that does happen, So try to give gentle traction. Don't be overzealous by pushing it. I've seen catastrophic bleeds because of that, and that's on table. But try to give a gentle traction while having your protamine prepared and connected to a three-way to the IV. In case it bleeds, then you can immediately shoot that. And if nothing is working, the microcatheter is not coming out, then just cut it, make a tunnel in the femoral system or wherever you have in the subacute region, implant it there, give antiplatelets and come out. Or like one, I think Dr. Matthew sir suggested this. If you have the option, then just push the entire microcatheter if you have over a sheath or something, and just pack it somewhere. Like suppose you're in the brain system, then just push it all in the ECA and pack it there somewhere. So something like that, but don't be very aggressive to try to pull it. If it's casted and it's stuck, then it's stuck. So if after initial trial it's not coming out, better leave it rather than be very aggressive with it.
One more last question. If glue escapes into pulmonary circulation while embolizing the EVM, what do you do?
Okay. You see, I had seen an interesting case of Dr. Jeffrey Chick from US, where he was doing a lymphangiography and a thoracic duct embolization, and mistakenly a lot of glue escaped through the lymphovenous anastomosis into the central veins, and entirely the bilateral brachiocephalic and the SVC, the glue had stuck. So he went in taking his flow retriever and clot retriever Inari devices, which we don't have yet in India, and he went into all those central veins and also the pulmonary arteries later, and he, like a standard thrombectomy for pulmonary embolism and central venous occlusions, he removed most of that cast, because usually glue that will fight this distal will be diluted glue. It won't be very hard and instantly. So I would say don't worry, don't panic, keep an eye on the pressures, keep an eye on the hemodynamics, immediately try to take whatever aspiration catheters or thrombectomy devices you have for the pulmonary system, go in and try to remove, if you can remove a few. Whatever is left and you can't do, just leave it. If the pulmonary pressures are fine and the patient is not instantly desaturating, then fine. There's otherwise last, I think there nothing else except a endarterectomy to call a CVTS and deal with it.
Thank you, Dr. Gaurav. These were excellent points and they were very helpful. And we are happy to see the response, because there are quite a good attendees which were benefited. And even the YouTube videos, this will be uploaded in the YouTube. You can ask your colleagues to just have a look at these videos. These are very informative videos. And my gratitude to all ISVR team. And thank you, Dr. Gaurav, for your excellent lecture. Now it's time to end this session.
Yes.
Thank you, one and all.
Thank you, sir. Thank you to all the attendees and especially the ISVR team. Thank you.